So this is my acknowledgement slide, and also I will say that I have no conflicts of interest. There's no financial disclosures that I need to report, but all of these people were instrumental in helping me do this work, especially the support that I received at Duke. And then I did receive, as mentioned, an F-31 grant and then 2 other smaller grants to help support this work. So my objectives today, I really kind of want to walk you through the population that I'm most interested in, those infants with medical complexity, and then really talk about the main concepts within my dissertation, which was confidence or parenting self-efficacy. And then really the main focus of my dissertation was to look at that development of confidence over time. And then I'm going to do kind of some summary implications and how we can think about this for clinical practice and then next steps during my postdoc and future career. So I want to pause for just a moment. Had I had a little bit more time, I wanted to insert a different slide here as an introduction, but I think this talk kind of comes really timely as November is actually Prematurity Awareness Month. The March of Dimes just released a lot of information about prematurity in the United States. And currently 1 in 10 infants are born prematurely, and it's also the leading cause of infant mortality in the US. So I think this is really timely. There's a lot of focus that's going into trying to reduce our premature birth rate. However, I'm not taking away anything from, those that experience a premature birth, but we have a lot of other babies that end up hospitalized with different types of complex care needs that you can't call them preterm. Maybe they have a congenital issue, a birth defect, maybe a complex heart condition, and they are very likely not born premature. They can go to like full gestation, and so they don't really collapse into that category. And yet they're neighbors to each other in the NICU and experiencing that same environment. And so when I talk about infants with medical complexity, we can kind of conceptualize them as having specific chronic conditions. And these are the infants that we think or we expect are going to go home with some kind of healthcare needs after their hospitalization. So this grouping does include some premature infants, but it also includes a lot of other diagnoses. And we're not really thinking about those infants that maybe are acutely hospitalized, say for bilirubin issues, maybe respiratory issues. That parenting experience is still really important, but though they have kind of a different trajectory. But we're still wanting to enhance the whole care environment for them. So this group of infants, we know that based on their diagnosis, even with a diagnosis, the range of their symptom experience can vary, but we know that they're often technology dependent. So by that we mean they may go home on medication, they may go home with feeding tubes, they may go home with oxygen, and so there's something that they need to kind of help support life and thrive. We know that they are high healthcare users, and so they're going to interface with the system, and usually they often have a lot of specialty services. So maybe they have to go to a cardiology appointment, a neurology appointment, maybe they're seeing PT. And so there's actually multiple touch points within that healthcare system that we can kind of look at and see what's important and how it impacts the family. So again, there's going to be substantial family identified service needs, and so there is some data to suggest that parents who have infants with medical complexity, there's a lot of financial burden, either from like losing their job because they have to be in the hospital with their infant, and then that's an added strain. They lose their job, maybe they lose their health insurance, and then there's no income coming in. And so there's also a significant impact on just the family structure and family dynamics. And so this is the area that when I started my work, I was really interested in because I wanted to try to understand what is it that we're doing in the care environment that can really help impact this family system. And so when I started my PhD program, I didn't really have the language and I wasn't really sure what concept I wanted to focus on. But I knew that what I was most interested in was how do we help build capacity in our parents? How do we really help them feel like parents when their infant is hospitalized? Because within the world of the NICU, there's a lot of talk about some of this gatekeeping, where parents feel like the nurses are really the one that are in charge and like in control of their infant, and the parents often feel really alienated. And so I came across this, I was aware of self-efficacy, but I wasn't sure how it was really going to play into this population. But as I started reading the literature more, I was really fascinated with this idea, especially all the work that Bandura did with his social cognitive theory about how self-efficacy really is a main driver of how parents may experience the world around them, how they may become competent in their interactions. And so that's why I chose to study parent confidence, because what we're really looking at is that parent's internal belief. So it's their internal structure about how successful they feel like they might be in engaging in these parenting behaviors. And then we know that their responsiveness and their engagement with their baby is really going to influence that infant's health and development. And so if these kids are really sick and they're going to go home with some kind of extra parenting related like caregiving requirements, we really wanted to see how this may play into that population. So I spent some time trying to understand what we know about confidence. And a lot of this data comes from cross-sectional studies. There's not a lot of longitudinal data. And a lot of the information comes from infants or toddlers that are healthy term-born infants, or what we would kind of classify as neurotypical. But I think it still helps us understand maybe some baseline of like how this may influence parenting. So if you are more efficacious, you're more likely to be resilient, better equipped in challenging situations. And that's one that I really, kind of latched onto, is like if you have multiple stressors, how you kind of engage with those stressors is really going to be important for parenting. And it has been associated with positive infant health status. However, conversely, if you don't really feel confident in your parenting ability, what might that look like? Well, we know that it can lead to maybe some social isolation. It is also influences your psychological health, whether it be perceptions of stress, your depressive symptoms, impacts on the family. And then this last piece is interesting because how they're perceiving their infant, that's going to lead to those interactions. So if a parent perceives that their infant has a difficult temperament, then are they going to be as responsive and engaging with them? And that's going to also influence their development over time. So as any good PhD student, there's a lot of I would say conversation around what do these terms actually mean. And it was drilled into me really early on that we need to be clear and operationalize of what it is that we're trying to measure. And so there was a lot of use of like different terms that crosses both the nursing literature and the psychology literature. So I wrote this piece as I was working on my grant to really try and help us get more clarity and understanding on, do these words mean the same thing? Or is confidence the same thing as self-efficacy? And then how does that relate to this idea of competence? Because a lot of times you would see in the literature, they would talk about perceived competence, and again, is that the same thing? So my key findings from this work, my mentor, my dissertation chair really pushed me to like land and like be emphatic about what I believed. And so as I looked at the literature and looked at the measures specifically that were being used, I really came to see that self-efficacy and confidence, they're actually synonymous terms, given the way that they're being currently measured. Partly because the wording within the scales, we're using the word confidence to operationalize self-efficacy. We're not asking a parent, how efficacious do you feel about feeding? We're asking them, how confident do you feel in this specific task? Where there was some clarity and more defined line was that when we use this word competence, we really want to be thinking specifically about an assessment that's done by somebody other than the parent. So this is really talking about that parenting quality and an assessment that can be done, kind of outside of a parent. So from there, I'm going to kind of switch for a few minutes and talk about some work that I did to really kind of help us think about like parent engagement and what does the environment look like within intensive care settings. And so I completed a study that we really wanted to look at unit leaders' perspectives about their intensive care environment. So this work was actually data from my mentor's R01 that was completed or that was done several years ago and funded through NINR. I did a secondary qualitative analysis where we were most interested in trying to understand how unit leaders were thinking about parent engagement and how they facilitated that interaction within their environment. And so the interviews were conducted with medical directors and nurse managers, both in a pediatric cardiac intensive care unit and the ICN, which is what Duke calls their intensive care nursery. Of course, they have to have a different name, than everyone else. But these interviews were great because they were actually conducted annually for 3 years. And so it was really interesting because you could kind of look at and hear them talk about changes and different care practices that were being implemented within the environment. So my findings for this was I came up with 3 main themes where it really focused around what were the things that the leaders were talking about that they felt like was supportive of parent engagement. And so this idea of this culture was really how that they created shared goals and practices that just kind of drove care delivery. And so we're really talking about care practices, care guidelines, visitation rules, family, sibling interaction, and those kinds of things. Then secondly, they talked a lot about kind of this relational aspect that has to happen in order for good care to be delivered. And so these are really that communication and interpersonal skills between parents and providers. And so they talked a lot about how there's a lot of like disconnect with communication and how it still was really difficult to get everybody on the same page. And then the last one was the environment, the physical space. And this is really going to be unique to what care setting and what environment you're in at each hospital. At least for them, they really thought that the design, the physical layout of the unit was really impactful as to like how engaging they could be with parents. There was a sentiment that if they could just change their environment, they could be more family-centered. Which I will just leave that there for now, which was one of the findings. And so I thought that this piece was really interesting because we were able to really see that there are many components that need to like work together in order to provide really efficient and quality parent engagement. And then each component is going to contribute its own aspects to that management of care and how those parents and providers are really trying to best care for those hospitalized babies. And then we have to be mindful that our physical space and design and how everything is set up is really going to impact care because it's going to drive certain care practices and really kind of set the stage for how parents are like introduced or even what they kind of see when they walk into that unit. So from there, we're going to kind of switch, and now I want to talk a little bit about my primary dissertation study. And this was really to develop knowledge about parent confidence within this specific population. As I mentioned before, a lot of the work that had been done related to confidence was not in a medically complex population. And honestly, not even among, hospitalized infants within a NICU at large. And so I thought it was a really great idea to try and explore. So my F31 aims, we really wanted to just get a baseline understanding of what confidence looked like over time. And then there were specific contextual factors that we were really interested in and how they influenced confidence. And then we really wanted to see if confidence or any of those contextual factors influenced specific parent and infant outcomes. And then the third aim was really to try and look at parent perceptions of confidence through some qualitative interviews. So this is my lovely conceptual framework as we kind of couch everything in theory and frameworks and really kind of help us understand the relationship between each of these components. And so you can see that in the middle, the arrow with the time was really kind of driven by a developmental science perspective, and really knowing that parenting does not occur in isolation. There's lots of different factors that go into this. And so the three contextual factors that we focused on were, there's lots of things you can choose, but we really wanted to make sure we had three main components. We had a family piece, and that's the family functioning. We really wanted to try and understand what that family looked like. We thought it would be important to understand the environment, and so we measured family-centered care, or kind of this idea of like health giving, that relational piece. And then we wanted to make sure we captured really what that infant looked like, and that their complexity and how that may influence parents. And then the dashed lines to outcomes. For this model, we took out the aims piece. For the F31, they told me that it was too ambitious, but my mentor was like, we're going to measure that anyway. And then the other things in the bubble are just, the other things that we know are going to potentially impact confidence. So the design for the study, it was a longitudinal multi-method exploratory study at 3 different time points. So enrollment was essentially kind of right after birth, within 3 weeks of being hospitalized. And then we followed them again at discharge from the hospital, and then followed up with them 3 months after discharge for the quantitative measures. And then after that 3-month time point is also when we did the phone interviews. And this was a timeline that we created just to kind of help us understand how long recruitment might take, and in the span of how long they may be in the study. This LOS, the average length of stay of 52 days, was data that I had looked at to kind of see, for this population of medically complex, how long do we expect them to be in the hospital. So I recruited from 2 different settings at Duke Children's, their intensive care nursery, or their NICU, and then their pediatric cardiac intensive care unit. That's where most of the complex heart kids went, and they kind of shared babies back and forth, and so I needed to recruit from both units so that I didn't lose a big population. And then for my sample, so we prospectively identified infants that may be eligible using a specific classification system, the complex chronic condition classification system. So this was developed by a researcher, an MD out of CHOP in Philadelphia, where he looked at IDC 9, and now they have IDC 10 codes of all of those kids that we think, from that very first slide, that may fall into this categorization of being medically complex. And so I was able to kind of match like that primary diagnosis or admitting diagnosis to see if they had a code that fell within this classification system. And our 4 main categories were our complex heart kids, the extremely premature. So this is really only going to capture those premature infants that are born from like 22 weeks to about 26 weeks. Then we have congenital birth defects and syndromes, and then other, which would be kind of your birth trauma, eye drops, some other kind of illnesses that may not fall within those other ones. One of the things, yes, I'm sorry.
You were going
to
comment on this, but does it include necrotizing enterocolitis in the non-extreme premature infants?
It does, yes. So we would include infants, like say that if they were, born, they didn't initially fall into this classification, but as I was reviewing everything, if they ended up with a diagnosis of something like NEC or BPD or some other issues, they would become eligible.
Thank you.
Yep. And one of the things that was really important to me was this non-categorical approach to my sample. And I got some pushback because they're like, you're going to introduce a lot of heterogeneity, like these babies are going to look different. But that's also why we have that measure of infant illness severity or complexity. And it was really important to me that we included babies and infants that are often excluded from all the other studies. Like, we need to understand what their trajectory and what their parenting and what these infants look like. And these parents are more than willing and were just as engaged in the research process as anyone. Yeah.
You use the term categorical.
Mhm.
And I'm just wondering for this audience,
Yeah.
perhaps you could elaborate on
Yes. So what I mean by that is not diagnosis specific. So I'm not focused on like a population of, let's say, just like premature infants, or only recruiting, say, like congenital heart, or a lot of people will focus on one specific diagnosis of like a congenital heart, or they may focus on like surgical infants who have like gastroschisis or maybe a myelomeningocele. And so this non-categorical approach really just means that we're willing to kind of include anyone and approach it that way.
but the implication that it's the cross-cutting issue that characterizes the experience rather than
Exactly. Yeah. So we're not thinking, yes, it's exactly. We don't think that it's the disease itself that's contributing to these factors. It's more or less that care environment, because also we know that even within specific diseases, there's a spectrum. You know, you can have an infant that has varying degrees of complexity even with the same diagnosis. Yeah. Thank you for that. And I probably should have said at the beginning, please feel free to ask questions, kind of stop me along the way. I'm happy to answer questions as we go. So the inclusion criteria for this study is we did need to make sure that these infants were going to go home with the parent given the longitudinal status. And for some of those extremely premature and conditions that really are not kind of compatible with life, if there was any concern or any question, we held off on enrollment, which is kind of why we had that 3-week time period. I worked really closely with the nursing staff and the medical staff within both units to make sure it was appropriate to talk to these parents. English speaking and reading, even though there is a significant Spanish and Hispanic population, the measures that I was using haven't been validated in that just yet. So we didn't include, yes?
One question about the complex chronic
Mm-hmm.
condition. Does it include a rating of dichotomous within each category criteria?
It's just that. If you have that, it's just all based on their IDC-10 codes. Yeah. We didn't also do multiple gestations because, again, having multiple babies, I'm not sure how that may affect it. And then I do acknowledge that we're leaving out a big portion of infants that are hospitalized, this acute diagnosis. We didn't enroll late preterm infants, which is a huge focus these days, which is a growing population. We didn't, even though they were hospitalized, we weren't focused on that for this study. So how did I collect all this data? So I developed online surveys, an online database through RedCap. And all of the surveys were emailed to parents at each of the 3 time points. So all the information was collected electronically. Parents were asked at consenting if they wanted to do that or if they had access to a computer or smartphone. I only had like 1 or 2 families that chose to do it on paper instead of electronically. And then the qualitative piece, I will get into that, but we proposively sampled parents for the interviews based on their confidence trajectories, and then we did narrative phone interviews with them at that 3-month time point. So the measures that I used, the main one is this Caratane Parenting Confidence Scale. And the number in parentheses is how many times we looked at each of the measures. So confidence, we were asking it all 3 times. The family assessment device looked at family functioning at the 3 times. And then number 5, the technology dependent scale, that's actually the measure that we used to be able to understand that infant health status or that caregiving complexity. And that says 3 times there. We actually collected that weekly on a lot of our infants. So I have some really great and robust data, hopefully to explore about really kind of what health status looks like over time in this population from that measure. And then I had a full interview guide. However, for this analysis and for my dissertation, we really just focused on really trying to understand having the parents describe what confidence means to them and what was most influential about their experience within the hospital. So I want to spend just a little bit of time on this measure that I used because it really helped inform a lot of the data that we were able to do in the subsequent analysis. So this scale is really specific to infants, to parents of infants 0 to 12 months. It does not specifically talk about hospitalized infants. There is currently not a great measure that looks at confidence within parents who have a medically complex child. There is a scale available for preterm infants, but again, that's not applicable in this population if they're just focused on what that prematurity experience may look like. But the thing that I liked the most about this scale was this clinical cutoff index. So it was validated in that scores greater than 39 would kind of indicate you're doing pretty well. You have some good confidence. You're feeling pretty stable with some of your parenting abilities. But then anything below 39, you kind of suggest that they're at clinical risk or they're in need of some more support related to parenting. And so that was really, it kind of helped inform our analysis, and I didn't have to kind of figure out kind of where they might land in terms of confidence. It was already built into the scale. So what did I do for the analysis? So we just kind of started with some descriptive statistics, and then for the main outcome of really looking at confidence over time and the influence of contextual factors, we did mixed modeling, and then from those mixed models and those betas, we did some multiple regression analysis related to those parent and infant outcomes. So I will also say one of the other limitations, or one of the data that I'm presenting to you today, is just the mother data. So I might have missed that in one of the slides, but when we recruited both moms and dads. And so we approached moms first and asked if they were interested, and then we asked if they had a partner. Marital status was not an inclusion criteria, just if there was a self-identified father, they were eligible. So I have the father data, but what I'm presenting today is just the moms. So in general, sorry, I think this is kind of small, but our mean mom age was about 30. They had 2 kids. And then we made education a continuous variable, so 6. So they're mostly, they had some college. And then the income, I do want to point out that given that we were at an academic medical center, there was a range in income, but we have a lot of like high income earners that I think it's important to identify. And again, for our kids, our length of stay was actually greater than the average that we had found in the previous data for those units. And then on average, each infant had about 3 chronic conditions within like their problem list. And so they're having kind of multiple issues. And then the other thing was interesting that most of them were discharged on at least 3 medications. And then here's the spread of those diagnosis categories. We're pretty, our percentage is pretty even across our sample. So again, this is these are the total scores and kind of their trend line, their mean trajectory for all of the moms in the sample at each of the time points. So the red dashed line is that clinical cutoff index. And so as we would expect, kind of around admission or when they were filling it out within that first 3 weeks of birth, their mean score was 38. And there was actually a wide range during this time. I think the range was like 10 to maybe like 41. So there's some substantial variability in those scores. And then by the time of discharge, they were at 40, and then 3 months after they were at 41. And I think for me, the point here is like there's not a huge jump in this time point. They're still kind of feeling they're at the same level. The next thing we looked at was family functioning. Now this scale, we have to look at the opposite way. So a 1 kind of is good or better family functioning, and then a 4 just down here at the bottom, that kind of indicates poor family functioning. And so our line is pretty much, the scores are the same. And then this is the measure of that complexity from that technology dependence scale. And you can see, like, as we would expect, we have really high complexity at birth. At discharge, we're still seeing, them being pretty complex, kind of pretty sick, the 16. So best scale looks at things like so what would contribute to these high scores is how many lines do they have? Are they in TPN? Are they intubated? How are they being fed? What is their skincare routine? And how many medications they're on? And it's kind of this cumulative score that the more interventions or more dependence, the more complexity you would have. And then you would hope and you'd kind of expect then as over time you kind of get better, this is clearly going to decrease because you're going to have less frequent monitoring or technology dependence. I think the point here for a 6 is this is still several medications, potentially oxygen at home. They're still having a lot of kind of healthcare issues or healthcare needs at discharge or at 3 months after discharge. Yeah.
So I think it's fascinating that the confidence scale is actually higher than the discussion before. And do you know what the population norm looks like for this scale? And is it similar or different?
It's actually pretty similar. So the other studies that have used this scale, the initial mean scores is right around like 37, 38. So we're kind of right within that range. And then I'm trying to think offhand because there's only a few studies that have kind of looked at it kind of over time, but they are seeing like similar increases. There was one study that I know that their initial or their baseline measurement using the scale, this initial time was 35, but that was kind of the lowest that I've seen within the literature is a 35.
I can't remember when you were talking about the sample, are they all first-time parents?
No. Yeah. There. I don't remember offhand, but there is. Oh yeah, here. So 50% of them, it was the first child, but we have 24 and 26 where they had kids. So yeah.
For the medical complexity,
each
thing weighted this for like. So if you're on medication, that's the same as being grapefruit dependent.
No. So yeah, great question. So within each kind of section that you're measuring, like the more, like if you have a PICC line and an IV, that's like kind of counted as 2. Like each thing kind of gets its own point. But I think to your question, the medication, it's weighted in terms of the type, the route, and the frequency. So it could be the same medication, but if a baby's getting it IV, that's going to be a higher score than a baby that's getting that medication orally. A lot of detail, like in collecting that, from the chart review. But yeah, so that is weighted. So the type, the route, and the frequency. So here is my mixed model analysis. So what we did initially was we wanted to just look at, again, that baseline confidence. So we created a model that we were just looking at confidence. The other thing that I do want to mention is that in each of these models, we controlled for length of stay that was centered around the mean. So that variable, actually, length of stay was not significant or predictive of confidence. However, we left it in the model because we felt theoretically that we needed to control for the variation in length of stay for all of these parents. Because I had a lot of questions from people as I was doing this work, like, well, is a shorter stay better or is a longer, if they've been in the hospital longer, then maybe they would be more confident. Which we didn't find that within this study, but we felt like controlling for length of stay throughout these models was important conceptually. So then each of them, so we then went, so we had model 1 and then Model 2, we just wanted to plug in our contextual factors, so really looking at family functioning, that family-centered care, and then technology dependence. And then we just kind of walked through, and then we did a model that had a lot of all of our variables. And then the last one, we just wanted to plug in to see what was significant. And I apologize that the lines are a little off-centered. But what we found that was significant, again, was this parent age, number of children, family functioning, and then this one is the big piece that everyone is super interested in, is the marital status, which was actually predictive of lower confidence over time.
Right.
Yeah.
First, what is event? What is
Event? Oh, that's what we labeled the time. So that's the change over time.
Okay, so this is a panel regression. Sorry, is this basically? I'm trying to understand what the regression is.
So this is the oops, sorry, our mixed modeling result, the mixed models that we did.
But,
yeah.
But the observations are at the person
level. Yeah.
Right, but person time level, right? Because each person has 3 observations.
Yes.
And so your regression is looking at. Sorry, is the coefficient the change in confidence as a function of changes in the predictors?
Yes.
Okay. So
yeah,
as events change, as you have a one unit increase in the event as you go from discharge to 3 months or whatever, there is a 1.79 increase in your confidence scale.
Correct.
Right? Unadjusted. Right?
Yes.
Okay.
Yeah.
Okay.
The dependent variable is the confidence scale continuous?
Right. So we plugged in, so the model was the confidence, their score. And so the intercept was their, like, the initial status, kind of like where they were at. And then the event, or was the time, looking at that confidence, that total score over time.
So at both time points, so you have baseline, and then you have discharge, and then you have 3-month follow-up.
Correct.
So event corresponds which one? Discharge or the 3-month follow-up?
Both.
In this case, you're weighting them equally. Right?
Correct.
You're considering a 1 unit increase from baseline to discharge, the same as from discharge to 3 months. And you were using fixed effects, right? Parent age doesn't change, right? So those are all fixed.
Yes. Yes. Thank you. Yes. These are the fixed effects in the model.
So did you run any models at those 2 times?
No, we have not done. No, I have not done that. Yeah.
I also, again, I'm going back to what you were saying too, that if the counterfactual, if in a normal, not complex kind of infant, like trend is always also up anyways, right? Are any of these kind of changes in FAD, complexity, are any of those like meaningful, right? Because I mean, you would think that without changes in technology dependence, so normal infant, right? Parents, their technology dependence stays dead zero, right? So, is what I'm getting at? Like it feels like a little bit like these explanatory variables don't matter as much if like the trend would have been upwards anyway.
Parents become
Like-
confident
over time, right?
Right. Yeah, like we naturally assume, yes, that they're gonna gain in confidence. I think that one of the main things that I was like wanting to do, kind of explore, it was like, do we think it's gonna like increase over time, in this population, or is it gonna be related to like our population norms? And just kind of give us some of that baseline data, and like, can we kind of understand what may contribute to that? I think that really like the next steps and some of the things that I'm working on actually now is really trying to do some like more growth analysis and growth trajectory, and try to really understand what is maybe predicted, because I anecdotally from seeing the data, I know that there's a lot more variability than this indicates in terms of what those different patterns of trajectories look like.
It would be interesting to look at the not first-time parents. right?
Mhm.
Because theoretically, they're parental confidence. You've already had a kid who might not be medically complex,
Right.
right? And so you already had a kid. You've already gone through that 0 to 12-month experience. And what then is their change over time for those that have 2 kids, for those that have 3 kids, when
Exactly.
that second and third kid is medically complex? That
Right.
would potentially address some of these concerns about
Yeah,
confidence
exactly.
increasing over time for all parents.
Exactly, I think so, and because there's some qualitative data that I have to suggest that they really speak to this in some sense. So I think that providing maybe some evidence to kind of what they're saying qualitatively would really be impactful.
I mean, even better is if you have the baseline data from a first-time parent who had a normal kid who was highly confident, and then they had a medically complex kid
Yeah.
to see if their confidence drops.
Right.
Yeah.
And yes, if I could have, yes, I wanted to. Yeah.
We can go back to the study now.
So I want to be really mindful of our time. I'm gonna like breeze through some other slides and kind of get to the ending slides. There's a whole nother chapter that I did where I compared the qualitative data related to the confidence question and how that kind of looked with their different trajectory over time. But I'm going to skip that. I'm more than happy to talk to people about that, but I just want to get to some of the ending slides. So I think that if we kind of just think about competence within the care environment, these 4 main areas are also kind of specific to, again, Bandura's social cognitive theory, that if we think about, there are really kind of 4 ways that we can kind of build confidence and build capacity. And so they really kind of center on, interacting with that infant, being close, kind of this idea of verbal persuasion, or how well they're able to kind of communicate with the healthcare team. And again, it's just then providing opportunities to really build that capacity. And then their psychological well-being and that emotional support. And so that's kind of just how I see, the interplay between the care environment and building confidence in this population. And I think overall, we've touched on a lot of implications and a lot of really great ideas and directions that we can take this work. I think that we're probably not asking the right questions currently, but I don't think we knew that until, we did some exploration. I do think that confidence matters, but there's also a lot of other things that I think come into play that we really need to think thoughtfully about and kind of potentially look at the same time. And it really speaks to this idea of like, how is care being delivered? What do the care models look like within our intensive care environments, and the support that they have? So my next steps, we've kind of talked about a lot of these already. In terms of that father data, I'm just really trying to see, again, do some analysis of like, how congruent is there congruence between the mothers and fathers, how do the fathers, where do they fall on those mean scores and trajectories and that kind of thing. And again, this idea of this new measure, we need something a little bit better when we're really thinking about, do they feel confident in caring for their medically complex infant? And so I've been thinking about some work to really kind of tie in, if we're measuring complexity using this technology dependence, kind of building questions around medical complexity. And then the other things, as I've been thinking about, especially as I starting to draft aims for a K award, is just really wanting to kind of understand, how long do they stay medically complex? At what does their care trajectory look like once they're home? And then how often are they interfacing with the healthcare team, and what are those pathways look like? And what is that health status? And then again, how does that play into this whole kind of parenting piece once they're home? And I think that's all I have for you today. Most of these slides, I end with this quote. I felt it was very applicable for me and my dissertation work, but also for these parents, that like, if you don't believe you have the capacity in the beginning, at some point you will acquire it. So thank you so much for all of your time and attention.